So yes, good evening everyone. Good evening bachas. How is everyone doing? Please acknowledge whether I am audible and visible. Please acknowledge whether I am audible and visible to everyone. Everyone. Okay, perfect. So finally, good evening everyone. So today we have gathered here to discuss some important INI predictor questions. Basically, we will be solving important MCQs, and I am not just going to focus on the MCQs. In fact, we will discuss that entire topic with a 360-degree approach so that we can learn all the important aspects of that particular topic. So we will talk about those topics one by one. Yani ki let's start solving those MCQs. Okay. So let us start with my first question. Now, I have tried to incorporate all the important questions which I want all of you to remember. Okay, so the first question with which I want to start talking about right now is going to be a young patient with anemia, splenomegaly, 42 positive, okay, 61 positive, very nice, and 19 and 3 negative. The consulting physician also reports presence of a genetic disease in the patient. Which of the following cytogenetic abnormality is most likely to explain the genetic disease in the patient? So if I go by approach word by word, flow cytometry here is very, very classical for me, because in my lecture I always say 41, 42, 61 positivity means these are your megakaryocytic markers, right? And bone marrow aspirate failed to yield much. Why? Because there was myelofibrosis. So myelofibrosis, megakaryocytes with 68% atypical large cells means I have megakaryoblast, and the classical point they have given is presence of the cytoplasmic blebs. Yes, you all know how do we recognize megakaryoblast. This I always tell in my lecture, that by the presence of chotu, q2, golus. What are these golus? Yes, these are the blebs present on the membrane, and the moment you see blebs, that means I am talking about the megakaryoblast. That means from all this information, my flow cytometry is also telling me megakaryoblast. My blebs on the membrane is also telling me megakaryoblast. Yani ki I am talking about a patient of M7-AML, and we all know that number one, M7-AML is associated with myelofibrosis, and number two, M7-AML, they are associated with Down syndrome. So yes, here my correct answer is going to be your trisomy 21, that is Downs. Very good, I can see correct answers now. But I want to talk about, if I look at rest of the options, 821 is seen in M2-AML. 1517 is seen in M3-AML, and you all know M3-AML shows what? PML RARA fusion, right? Because of which you have decreased vitamin A activity in these patients, and that is why the treatment of choice is your ATRA, all trans retinoic acid. And we all know M3-AML, they are also associated with DIC, and you see Faggot cells also. See, I'm covering the high yielding crisp points which you need to know. But rest, if I talk about your inversion 16 is classically seen in your M4-AML. in version 16 in M4-AML. So this was all about your very important M7-AML and some important things which I want all of you to remember for your rest of the options. And yes, one more important point I need to make a mention, that if I am giving you 3 translocations, 821, 1517 and inversion 16, so these are what? Exception. Remember the lecture, exception wala translocations, because in these 3 translocations I do not care irrespective of the blast count. I do not care about the blast count. My diagnosis is always going to be AML, right? Because we know WHO has told me that more than 20% is diagnostic of AML, but here, irrespective of the blast count, I will always say that this is a diagnosis of AML. Done? Chalo. Great. Good. Next question. Move towards the next question. Next question is saying me that I have a 29-year-old RHD negative woman coming to me with amenorrhea. UPT is positive and you want to do the, listen. You want to do the indirect Coombs test to confirm if she is already sensitized to RHD. In which of the following vacutainers should you be sending the sample for the test? Very straightforward. देखो इतना history दिया है, but I have to focus that what I want to do. I want to do the indirect Coombs test, and for indirect, you know that in indirect Coombs test, basically we detect the presence of antibody in the serum of the patient. So here I want to do the serum studies, and yes, you know that for serum studies either we use a golden yellow vacutainer or we use a red cap wala vacutainer, right? So correct answer is going to be very good. Correct answers I can see in the chat. Very nice. But if I look at the rest of the options, purple or the lavender. Purple or the lavender is going to contain what? EDTA, and we use it for complete blood count. What about the gray one? Yes, gray contains your sodium fluoride. Yes, we use for sugar estimation. And blue is your citrated blood, and we use that for coagulation studies, right? So these are your important vacutainers, and I want all of you to please remember them. Very, very, very important. Okay. Now, please, I request you that if you are focusing on INI, there are few favorite topics of INI. One is the stain. Stains are very, very favorite for INI. So let us talk about these stains now. I have a question in front of me and you have to match them. First of all, let's go for melanin. Melanin ke liye I use a Mason, but which Mason? Mason, yes, Fontana. So 1 is 4. And the moment I see this, A option gone, B option gone. Cut diya humne. Ab bacha C and D. Next, go for the copper. Copper is going to be yes. 1, 2 ka 1. Yahin se hi I know my correct answer is option D here. But yes, for completion purposes, I'm going to complete. For copper, you need rhodamine and also you need rubianic acid is also one more stain. Now collagen ke liye also Mason, that is Mason trichrome, and calcium ke liye you need von Cosa. But if I am saying that it is favorite of INI, so let us cover all the important stains that you want to know. Number 1, hemosiderin. For hemosiderin, you need to have Pearl's Prussian blue stain. For copper, you know one is your rhodamine and second is your rubianic acid. Yes, very good. Ceruloplasmin. Remember, please, this is a transport protein of copper. For that, you need Orcine stain. For fats and lipids, you need oil red O and Sudan black B. And please remember, oil red O is particularly and only used for your frozen section. If I'm being calcium, yes, we know that is von Cosa stain and your alizarin red S. Von Cosa and alizarin red S stain. Okay. Next is going to be your glycogen. Glycogen, yes, glycogen is going to be pass positive. And pass se related, what else you need to know? That if I talk about your hematology, your lymphoblast, they are also pass positive, and your erythroblast, they are also pass positive. But the difference is in the pattern of the staining. In lymphoblast, you see dot-like or block-like positivity, whereas in erythroblast, you see very good diffuse or circumferential positivity. Very, very important. Next, PYQ for mast cells, we use a toluidine blue. And for amyloid, the most important stain that you have to remember is your Congo red stain. Yes, apart from that, you can also use thioflavin T, thioflavin S, crystal violet, methyl violet, PAS, Elchin blue. Those are the other stains, but the most important one that I want all of you to remember is your Congo red. And we all know that Congo red on polarizing microscopy will give me a characteristic, yes, apple green birefringence. Right? These are the important classical questions which I want all of you to please remember. Now, देखो ऐसा हो ही नहीं सकता. It is not possible. If I have taken a amyloid name, I cannot skip this part. Whether there is a question or not, I just want to talk about it because this is highly important. Nature of amyloid. So for multiple myeloma, the nature of amyloid is going to be AL. For chronic renal failure or hemodialysis associated amyloid, that is going to be your A beta 2 microglobulin. And remember, A beta 2 microglobulin is hemodialysis, and for Alzheimer's, it is A beta. For type 2 diabetes mellitus, it is AIAPP. Islet amyloid polypeptide. For medullary thyroid carcinoma, this is ACAL, where A stands for amyloid and CAL stands for calcitonin. For chronic inflammations like rheumatoid arthritis, TB, that is AA. For familial Mediterranean fever, also, yes, AA. For senile systemic amyloidosis, that is, yes, very good. I can see the correct answers pouring in. ATTR. A stands for amyloid and TTR stands for transthyretin. For familial amyloidotic polyneuropathy is also ATTR. Then what is the difference? That in senile systemic amyloidosis, this is the normal ATTR, and in ATTR familial mein, it is the mutated ATTR. Both have amyloid in the form of transthyretin, but in senile systemic, it is normal TTR, which is overproduced, and in familial amyloidotic polyneuropathy, it is the mutated transthyretin. Done and dusted. Let's move to the next question. Next question says that I have a 55-year-old male presenting with bone pain for the last 3 years. PBS shows, yes, 22% of the plasma cells, which are okay. There is a monoclonality also being established, lambda restricted. Serum calcium is elevated and IgG is 32 grams per liter. Which of the following is diagnosis? Now, please, I want to request you all, please read the question carefully. That plasma cells, increased plasma cells, you see where? In bone marrow or peripheral smear? So the question is particularly saying peripheral blood smear. No, yes. That is why I'm saying I can see the answers in the chat box. Please listen to me carefully. तभी ये लिखा गया है. That is always there to confuse you. The moment you see peripheral smear in the question, the answer is always going to be plasma cell leukemia. It is not at all multiple myeloma. When question says bone marrow may you see increased plasma cells, then the answer is multiple myeloma. But when the question says in the peripheral smear, more than 20% of the plasma cells you see, that is diagnostic of plasma cell leukemia. Please, I do not want any confusion now. Yes, गड़बड़ नहीं होनी चाहिए. More than 20% plasma cells in peripheral smear, straightforward. Answer is plasma cell leukemia. Students who attend my lecture, they know this, that I always repeatedly say, please, no mistake. And I have talked about this topic, so let's cover 360-degree approach to this topic. सब कुछ complete कर लेंगे. First of all is, if I'm talking about plasma cell disorders, we need to know about a CRAB criteria, one of the favorite topic of your INI, repeatedly asked. CRAB क्या होता है? It is an acronym where C stands for what? Hypercalcemia, means calcium more than 11 milligram percentage. R stands for renal failure. And when you say renal failure, when the creatinine values are more than 2 milligram percentage. Where A stands for anemia. Lambda restricted means, see, multiple myeloma is a tumor of which cells? Plasma cells. What is the normal function of plasma cells to secrete? Immunoglobulins. And if I have a tumor of plasma cells, so that means in multiple myeloma, you will see hell lot of immunoglobulins, right? And next question, in multiple myeloma, which chains? Because you know there are two chains of immunoglobulins, light chains and heavy chains. So in multiple myeloma, which chains are going to be more secreted? Light chains are going to be more secreted. And you know they are of two types, lambda and kappa. Next question is, which chains are going to be more secreted? Any. लैम्डा भी ज्यादा बन सकती हैं और कापा भी ज्यादा बन सकती हैं. So basically, if I'm saying that I have a multiple myeloma in which I will have more of lambda chain secretion, so I will say this is a lambda restricted multiple myeloma. But if I say in this patient I have more kappa chain secretion happening, so I will say this is a kappa restricted multiple myeloma. I hope it is clear to you, MD Medicine now. ठीक है? Done? Understand? Next, I was talking about CRAB. So A stands for anemia. Now, when do you say anemia? If the patient's hemoglobin is less than 10 gram percentage. So if the patient's hemoglobin is less than 10 gram percentage, or if you have a previous value of that patient, and in that patient's report, the normal now hemoglobin is 2 gram percentage less than the previous value. And B stands for bony lytic lesions on the X-ray. Right? Now, if you look at the options, I have given options like MGUS and smoldering and multiple. So I do not want to take a chance कि if a question from these options come, I want all of you to solve those questions. So मैं कोई chance नहीं छोड़ रही. I will tell you when I will call a patient as a patient of monoclonal gammopathy of undetermined significance. So this is a particular criteria that you have to remember. So to call a patient as a patient of MGUS, my serum immunoglobulin levels should be less than 3 grams per deciliter. Look at the unit. Either the question will say less than 3 grams per deciliter or less than 30 grams per liter. गलती नहीं करनी है. Do not get confused, right? Look at the units here. Next, bone marrow plasma cells should be less than 10%. And CRAB criteria should be completely absent. If all three things are met, I will say that this patient falls in the category of MGUS. Now, if I talk about smoldering myeloma, what criteria has to be met? Number one, my serum immunoglobulin levels should be more than 3 gram per deciliter. My bone marrow plasma cells should be between 10 to 60%, and CRAB criteria should be still absent. If I see all these three criteria to be fulfilled, I will say that this is a clear-cut case of smoldering myeloma. Now, if I talk about multiple myeloma, a repeatedly asked question that what is the new criteria of multiple myeloma? Number one, if I do the bone marrow examination, my plasma cells should be more than 10%, or on biopsy, I will prove that there is a plasma cell tumor, यानी कि biopsy proven plasmacytoma. तो इन दोनों में से amongst these two, anyone, if I see, good to go for me. Either bone marrow plasma cells more than 10% or biopsy proven plasma cell tumor. Now, amongst these two, one thing has to be there. Plus means and. Now, I'm not saying or, I'm saying amongst these two, one has to be present, and there should be any one of the myeloma defining events. Now, I want to know what are these myeloma defining events. Number one, CRAB criteria should be present, or biomarkers of malignancy should be present, and I'm going to tell you different biomarkers, and amongst that list of biomarkers, if any one biomarker is present, good to go for me. I am happy. I am sufficient. मुझे खुशी हो गई है. My diagnosis is complete. Now, what are these biomarkers of malignancy? Number one, bone marrow showing more than 60% of plasma cells. Number two biomarker, more than one focal lesion on MRI of 5 millimeter size. And number three, involved to uninvolved light chain ratio more than 100. Now, इसका क्या मतलब है? What do you mean by this? So I just told you that your multiple myeloma can be either lambda restricted or it can be kappa restricted. So say for example, I will say, example ले लीजिए. For example, I have a patient of multiple myeloma, and in that patient, for example, this is a lambda restricted multiple myeloma. So that means involved chain is lambda, and the ratio of involved lambda chain to the kappa chain should be more than 100. And obviously, it says that lambda chain should be more than 100 times being formed as compared to the kappa chain. मतलब lambda chain 100 गुना ज़्यादा बननी चाहिए as compared to the kappa chain, and obviously it makes sense. It's a lambda restricted multiple myeloma, so obviously I will have hell lot of lambda chain as compared to the kappa chain, and this what this biomarker of malignancy means. So this was your entire criteria of multiple myeloma. But फिर वही बात, again, I am not going to leave you in the mid because I want to cover every important thing that you need to know from multiple myeloma. So if I look at multiple myeloma, if you see, this is your plasma cell. This is your eccentric nucleus of the plasma cell. Can you see these things in the nucleus of the plasma cell? What are these? Yes. These are the intranuclear inclusions, which are called as what? Yes, these are called as Dutcher bodies. Very important. What is the location? These are the intranuclear inclusions, Dutcher bodies. Okay, next. If I'm looking at my multiple myeloma patient, again, this is your plasma cell. This is the nucleus of plasma cell. But can you see these golus here? Kahan present hai? Where are these golus present? Inside the nucleus? No. They are present inside the cytoplasm. And I'm talking about your, yes, these are your Russell bodies. And the location is intracytoplasmic bodies. Important bodies that you're going to see in multiple myeloma. See, humble doctor, if your biomarker of malignancy bone marrow more than 60% is C, so automatically, common sense, my first criteria is already met, right? So if in the biomarker, say for example, you have the focal lesion on MRI. So for that, your first criteria of bone marrow plasma cells more than 10% has to be there. But if in the biomarker you are saying bone marrow more than 60%, so 1 and 2 automatically, common sense, they are met, and I have a diagnosis of multiple myeloma. Clear to you, humble doctor now? Okay? Now, let's see here. What are these cells? Again, I'm talking about multiple myeloma. It seems this is my plasma cells, and I have, oh my God, fire, flame coming out. So yes, this is called as your flame cell. These are called your flame cell. Now look here. Yes, look here. Grape-like clusters. Yes, grape-like clusters of Russell body. So when you see grape-like clusters, this cell is called as Mott cell. Grape-like clusters of Russell bodies, this cell is called as Mott cell. Clear? So these were your important finding cells that I want all of you to appreciate in multiple myeloma. Now, if I'm making a diagnosis of multiple myeloma, if I'm talking about a patient of multiple myeloma, it is impossible that I do not talk about this very important repeatedly asked question, that is serum protein electrophoresis, that we do in this patient of multiple myeloma. So in multiple myeloma patient, you see a particularly, if you see here red color पे focus करेंगे, that is your patient. So I see a peak at albumin, another peak at alpha-1 globulin, another peak at alpha-2 globulin, another peak at, I will see a peak at albumin, another peak at alpha-1 globulin, another peak at alpha-2 globulin, another peak at beta-2 globulin, and you see, I see a peak at gamma globulin, and this peak is called as M spike. And what does it say? That means Gamma globulin is what? Immunoglobulin. So M spike means I will have a hell lot of immunoglobulins synthesis in this patient. And always remember that serum protein electrophoresis has to be followed by another technique of immunofixation to establish the monoclonal nature. Yani ki I want to know that which antibodies are being more formed, whether they are IgG, IgA, M, D, E, and if I know that this is IgG being more formed, then I want to know which chain, whether kappa or lambda. So to establish the monoclonal nature, serum protein electrophoresis is always followed by immune fixation. And on serum protein electrophoresis, I see very important M spike. That means I have a high peak at the gamma globulin region, which tells me that I have more amount of immunoglobulin synthesis. Clear to everyone? Now, when I'm talking about this patient of multiple myeloma, so your new international staging system has given me 3 stages of this MM patient in stage 1. Now, this is the criteria which you have to remember. The stage 1 means when I'll say that this is a stage 1 multiple myeloma patient, when the serum beta 2 microglobulin levels are less than 3.5 milligram per liter. Be very sure of the units here. Stage 3 multiple myeloma means serum beta 2 microglobulin more than 5.5 milligrams per liter. So stage 1 serum beta 2 less than 3.5 milligrams and serum albumin more than 3.5 grams per deciliter. And stage 2, my personal favorite, because if does not fit in 1 and 3, I will call at stage 2. So these are the values that I want all of you to remember, because these serum beta 2 microglobulin and serum albumin levels we also use for the follow-up of this patient of multiple myeloma. Okay. Right? Yes, Omkar, I said that if you want to diagnose this patient, so you need to have that entire criteria, that either bone marrow plasma cells more than 10% or biopsy proven plasmacytoma and any one of the myeloma defining events. If you go back, if you look here, I particularly said कि diagnosis के लिए this criteria has to be met. This criteria has to be met to make the diagnosis of multiple myeloma. Okay. So this M spike, see, this is a PYQ only, that M spike, is it a component of the criteria of multiple myeloma? No, it is not a criteria of multiple myeloma. Please remember, criteria यही है जो हम पढ़ रहे हैं. This is the exact criteria. ठीक है ओमकार? चलो. This is done. This is done. My multiple myeloma is done with the important things that I want all of you to remember. Now, the next question for all of you. Hanji. Question says, a 58-year-old patient with history of smoking presents with a lung mass on performing biopsy. Cells with high NC ratio, stippled chromatin and high mitotic rate were found. The electron microscopy shows the following. Genetic analysis of these tumor cells is most likely to reveal. So if I look here, what no? Please ask the question. Meenakshi, okay, look here. Look here, look here. On electron microscopy, I see these classical. What are these? Yes, electron microscopic image. And I see the classical presence of neurosecretory granules here. Right? Neurosecretory granules. That means I am dealing with a neuroendocrine tumor here, and the important neuroendocrine tumor of lung that I'm talking about here, with a history of smoking, with high NC ratio, salt and pepper, stippled chromatin, a very aggressive tumor with a high mitotic rate. Yes, I am dealing with a small cell lung carcinoma here, and we all know that small cell lung carcinoma may, yes, absolutely correct you guys are, I see L-MYC amplification. Yes, my correct answer is going to be option B. But if I look at the rest, your KRAS mutation and EGFR mutation, they are for your lung adenocarcinomas. Now, if I'm talking about these c-kit, yes, very, very important. Just You know that gastrointestinal stromal tumor, you see SICKIT mutation. But I'm not going to leave you guys here. No. I will give you all the important oncogene mutations that you need to remember for your INI. Look here. Number 1, I'm not going to leave you with these 4. No, I'm not going to do that. Giving you a 360-degree approach. RET mutation. If I have loss of function mutation of RET, you are going to have Hirschsprung disease. Loss of function mutation, Hirschsprung disease. ALK mutation. ALCL, anaplastic large cell lymphoma and adenocarcinoma of lung. SICKIT, very important, very, this is the most common mutation of GIST. ABL in CML and ALL, very important, 922 translocation. KRAS is colon carcinoma, pancreatic carcinoma, right? Very important. HRAS, kidney and bladder tumors. NRAS, melanomas. Notch mutation, ALL, CLL, dono la. ALL, CLL. CMYC, yes, starry sky appearance. Yes, I'm talking about Burkitt's lymphoma here. Next, LMYC, यही तो सवाल था. Small cell lung carcinoma. N for NMYC, N for neuroblastoma. EGFR, see, also called as ERBB1 in lung adenocarcinoma. ERBB2, which is also called as HER2 in breast carcinoma. Yes, very important. Next, BRAF mutation in HCL. What is HCL? Hairy cell leukemia. And LCH. See, HCL, reverse the alphabet. HCL, reverse the alphabet. That is going to be your LCH, Langerhans histiocytosis. The exact name is BRAF V600E mutation. Next is going to be JAK. JAK is going to be, yes, that is for Ewing's. JAK is, wait for that. I am going to cover that also. Okay. Dr. Puneet, just wait. JAK is going to be for your myeloproliferative neoplasms, your polycythemia, essential thrombocythemia, right? Next is going to be cyclin D1 for your mantle cell lymphoma. Okay, next. Chalo, these were my important oncogenes and their important mutations and associated cancers which I wanted to discuss with all of you. Chalo, now if I'm talking about lung cancer, again, I said, Puneet, I'm going to talk about it because another important topic for, I should say, favorite of your INI is going to be your IHC markers. They have a special love for them. So I cannot forget about them. So if I talk about the IHC important markers for SCC, any squamous cell carcinoma, whether it's lungs, esophagus, I do not care. They are going to be P40 positive, P63 positive. For lung adenocarcinoma, they are napsin A positive and TTF1 positive. For any neuroendocrine tumor, whether you say small cell carcinoma or any neuroendocrine tumor, they are going to be synaptophysin positive, chromogranin positive, NSC, neuron specific enolase positive and CD56 positive. For mesothelioma, BAP1 positive and calretinin positive. Important IHC markers for mesothelioma. Yes. For GIST, yes. Most common IHC marker for GIST is SICKIT, which is also called as CD117. But if I am being asked most specific marker for GIST, that is going to be DOJ1 positive. For intestinal adenocarcinoma, CK20 positive, CDX2 positive, SADB2 positive. For every glioma, whether it's your astrocytoma, oligodendroglioma, ependymoma, or glioblastoma, all glial origin tumors are going to be GFAP positive. For meningioma, Vimentin and SMA positive. For schwannomas, S100 positive. For seminomas, OCT34 nano positive. For prostate adenocarcinoma, PSA, AMACR, ERG positive. Right? Important. Important list that I want all of you to remember. For medullary carcinoma of thyroid, calcitonin. Pause a little. Important questions. For most common mutation, for papillary, most common mutation is BRAF. For follicular thyroid carcinoma, most common mutation is RAS. And for medullary thyroid carcinoma, most common mutation is RET. Okay, now coming back to the IHCs, Ewing's, देख लीजिए कहा था CD99, but nowadays the best marker for Ewing's is NKX 2.2. For yolk sac tumor, AFP positive. Yolk sac tumor, which body you see? Which body? Yes, Schiller dual body. Yolk sac, another name, endodermal sinus tumor. Granulosa cell tumors, inhibin positivity. Which body you see in granulosa cell? Yes, Kohl-Exner bodies you see. Yes, right, Meenakshi, that is a tumor marker. Okay, next. So this is all about this very important question and all the important things that I wanted to discuss with all of you. Now moving ahead to my next question. Next question says that on colonoscopy biopsy, it was done from a 10-year-old patient presenting with bleeding per rectum from past 1 year. Now histopathological findings are shown in the given image. All are true regarding this diagnosis except, means I am being asked about false statement. Now if I look here, कुछ लग रहा है देखा, can you see something that I have remember in the lecture? I always say the pink muscle is trying to separate. See, the pink muscle is trying to separate my glands. Yes, this is your characteristic arborizing network. Yes, or Christmas tree pattern. Yani ki I am talking about a PJ polyp here. Please have a look here one more time. I want this to be crystal clear. See a highly magnified image again. See, this is what? Pink muscle. And I'm trying to trace the muscle. Muscle is going here, pink muscle, 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 and pink muscle. And what it is trying to separate? Yes, all these are glands. All these are glands. So my muscle is trying to separate my glands. This is what you call as arborizing network, which is also called as Christmas tree pattern, a classical one of PJ polyp. See one more time. You know, this is so important that I want all of you to please imprint this classical microscopy. Again, look at this pink. What is this pink? Muscle. Okay, I have traced this muscle. Again, yes, it is trying to separate my glands. Classical arborizing network. I am not going to stop. I will tell you a low magnification power image. Abhi, I showed you 3 high magnification. This is again, see, a Christmas tree pattern. Again, see, what is this? This is a low magnification power image. I see pink muscle, pink muscle, pink muscle, pink muscle, and these are my glands. This is again your arborizing network or Christmas tree pattern. So that means I'm dealing with a clear-cut case of PJ polyp. Now coming back to the question. Now we all know PJ polyp, which mutation? Yes, STK11 or LKB1 gene mutation. Now look at the options. You see pigmentary changes in skin and mucous membrane around the mouth. Absolutely true statement, which is we call as mucocutaneous hyperpigmentation. बिल्कुल दिखती है. Most common pattern of inheritance is autosomal recessive. Absolutely false, and this is my answer because PJ, Peutz-Jeghers syndrome, they have autosomal dominant mode of inheritance. They can initiate intussusception. Absolutely true. Most commonly seen in small intestine. Absolutely true. Very important. Right? Okay. Chalo, this question is done. Let me move ahead with your next question. हाँ जी, आपके सामने रखा गया है match the following. Match करिए please. Match the following. Okay, so I have to match the paraneoplastic syndrome. If I go ahead, SIADH. Yes, SIADH is your small cell lung carcinoma. So A is your 4. So this is gone, this is gone. Acanthosis nigricans is your, B is your 3, gastric carcinoma. So this is gone. Correct answer is option D, but still let me complete. Myasthenia is going to be your thymoma and hypercalcemia is your SCC lung. Yes, correct answer is option D here. But फिर वही बात, I am not going to leave you here. Let us talk about this very important table, list of paraneoplastic syndromes. So for hypercalcemia, as a paraneoplastic association of squamous cell lung carcinoma, breast carcinoma, renal cell carcinoma. Cushing's and SIADH, both are small cell lung carcinoma. And in fact, Lambert-Eaton syndrome is also seen in small cell lung carcinoma. Next, hypoglycemia in fibrosarcoma, polycythemia in RCC, hepatocellular carcinoma, hemangioblastomas, Trojo syndrome as a paraneoplastic association in bronchogenic carcinomas and pancreatic carcinomas, myasthenia, bronchogenic carcinomas and thymomas, acanthosis nigricans in gastric adenomas, and pure red cell aplasia again in thymomas. Important list of all the paraneoplastic syndromes that I want all of you to remember for your last minute revision. Very important high yielding table. Please, please, please do not forget about this. Okay. Next question. Next question says that I have a 28-year-old patient presenting to me with proteinuria and hematuria. Okay. Renal biopsy demonstrates characteristic histological findings. Which of the following etiologies cannot be responsible? ध्यान से, cannot be responsible for this condition. I am seeing this biopsy और ये biopsy चीख के बोल रही है. This biopsy is shouting to me that I see a classical chanda mama, means I am seeing a classical crescent formation here. That means I am dealing a case of RPG, and that is crescentic glomerulonephritis. I am not going to go and look at the options. First I will teach you, then we will solve this. And we all know that I have a classification of RPGN on the basis of the immunofluorescence, in which I have 3 types: type 1, type 2 and type 3 RPGN. Now type 1 RPGN is going to involve those nephritic syndromes which have linear immunofluorescence, and who are going to be there? Goodpasture and anti-GBM glomerulonephritis. Why I have kept Goodpasture separate? Why? Because Goodpasture is also anti-GBM. Yes or no? Yes. Q. In Goodpasture, remember, you have an antibody formation against the NC1 domain of alpha 3 chain of type 4 collagen. Yes, yes, yes. So Goodpasture is also anti-GBM. Yes, but I have kept Goodpasture alag, separate, and anti-GBM glomerulonephritis separate, because in anti-GBM glomerulonephritis you will have no lung damage, and in fact the classical history of Goodpasture is a patient with hematuria and hemoptysis. If a question on Goodpasture has to come, this is a classical history of Goodpasture, because in Goodpasture you see lung damage as well. Okay, next, if I talk about type 2 RPGN, all those nephritic syndromes who have granular immunofluorescence are going to come here. Who are going to come under this? PSGN, lupus, IgA nephropathy and HSP. Now, if I talk about type 3 RPGN, this is pauci-immune. This is pauci-immune. Pauci-immune means less immunofluorescence. Who are going to come here? Vaginous granulomatosis and your microscopic polyangiitis. Now you know 3 types of RPGN and you saw who all are going to come under all these types. Now go and look back at the question and see. हमसे पूछा गया है, we are being asked which cannot be responsible for this condition, and the condition is RPGN. PSGN. Did we see this in type 2 RPGN? So it can cause RPGN? Yes. Vaginous granulomatosis. Yes, I saw this in type 3 RPGN. This can also cause RPGN. Goodpasture. Yes, I saw it in type 1 RPGN. So this can also cause. PAN is not an etiology. PAN is not a cause of RPGN. So yes, Microscopic polyangiitis is, but polyarteritis nodosa is not. So correct answer is going to be option D here. Clear to everyone? Yes, very good. Now going to my next question. Okay, yes, see, read the question carefully. गलत जवाब नहीं, क्वेश्चन ध्यान से पढ़ना है. A 10-year-old child is having chronic history of anemia, was doing well on hydroxyurea therapy. Suddenly he had high grade. Suddenly, oh my God, चल रहा था, okay, the patient was doing fine, but all of a sudden, patient is having high grade fever and a downhill cause, deterioration of the patient. And the blood investigations reveal hemoglobin of 6 grams per deciliter and a retic count of, okay, 0.2%, means I see what here? I see reticulocytopenia here. Retic count is decreased here, and okay, I see sickle cells and target cells. Which of the following mechanisms would have led to the downhill cause? See, I can see the answers pouring in the chat box. That's why in the beginning I said read the question carefully. यहाँ पे I am not talking about the cause of the sickle cell anemia manifestations. I particularly mentioned that all of a sudden patient is deteriorating in front of you. And whenever I say all of a sudden, that means this is going to be a crisis. And always in my lecture, I always say that for all the hemolytic anemias, when I talk about, there are two crisis complications. One is aplastic crisis and the another one is hemolytic crisis. This is a screenshot from my class only. And aplastic crisis is because of parvovirus B19 infection, which destroys your proerythroblast, which causes a sudden drop in the hemoglobin. And use your common sense. Aplastic crisis, your bone marrow proerythroblasts are damaged. And if the first cell of the erythroid series, the proerythroblasts are damaged, so is it possible that in future all the erythropoiesis will happen, my reticulocytes are going to come? Is it possible? No, it is not going to be possible. That means in this patient, my retic count is going to be decreased. But if I talk about hemolytic crisis, it is also because of certain infections. My patient all of a sudden deteriorates. Infections like malaria, EBV. Here, the name itself is saying hemolytic crisis, means I will have hell lot of hemolysis here. And you know that your bone marrow, whenever you have more RBC destruction, your bone marrow tries to compensate by producing more RBC, by doing more erythropoiesis. So that means in this case, I will have more retic count. So in this question, all of a sudden deterioration means there is going to be a complication, there is going to be crisis. But you see a classical reticulocytopenia, which is a case of aplastic crisis. So yes, here the answer is going to be your option B, that is aplastic crisis. I am not talking about that I have a sickle cell patient. In those sickle cell, your reversibly sickled RBCs are sticky now, occluding the lumen, leading to vaso-occlusive crisis. I'm not talking about that. I'm talking about a sudden deterioration of the patient in front of you. That is a complication. Otherwise, the patient was doing fine, and that is a classical crisis. And if I see reticulocytopenia, so that is not hemolytic crisis, that is going to be your aplastic crisis. So this is going to be your option B here, right? Now, this was very, very important. I hope it is clear to everyone. Is it clear? Yes or no? Yes or no, please? Clear to everyone? The answer is aplastic crisis here. Okay, now moving ahead to the next question. Next question says a 25-year-old lady with, okay, very careful, classical MCQ clue points. A 25-year-old lady with epilepsy is desirous of becoming pregnant, is found to have anemia. Examination of peripheral blood shows RBC count 3.2 million, hemoglobin 10 gram per deciliter, okay, MCV 110 femtoliter, MCH 27 picograms, retic count of 1%, RDW of 15. Which of the following is most likely cause of anemia? Which of the following is most likely cause? Hanji. Classical MCQ, epilepsy. So if this female is having epilepsy and also MCV is 110, that means I am dealing with a macrocytic anemia here. So this cancels my option D. Iron deficiency nahi ho sakta because it's a microcytic. Now I have to choose from A, B and C. Now I classically tell this in my lecture that if I am talking about epilepsy, epilepsy means that this female must be on a treatment, anti-epileptic treatment, and phenytoin, an anti-epileptic drug, is shown to show folate deficiency. So that means I am dealing with characteristic option C. Very good, correct answers I can see, folate deficiency. But apart from that, what else can be the causes of folate deficiency? Classical folate deficiency ka ek aur, there is one more way of getting this folate deficiency question. If the question says that you have a patient who is eating junk food and less veggies, fresh fruits and vegetables, so that is also a classical MCQ of folate deficiency. But if question wants to me ask about B12 deficiency, so for B12, what can be the classical MCQ scenario? Say for example, they can give you a history that the patient is a classical vegan, right? Vegans have B12 deficiency, and they can also give you classical hyperpigmentation of knuckles. And one more important, if there are neurological complication, so B12, because in folate you have no neurological component. So these are also some differentiating points between your B12 and folic acid on the basis of the MCQ clue points. Okay? Done? Okay. Now let's move ahead. Next question. The storage temperature of RBC, platelet and fresh frozen plasma are. Now always remember one point. There is one person who always gets upset whenever you talk about freezing temperature. एक ऐसा component है जिसको ठंड बिल्कुल पसंद नहीं है. Never likes freezing temperature, and that is going to be your platelet. Platelet always wants to stay close to the room temperature. So the moment you say thandi, cold, platelet is going to get naraz. So if I see platelet minus 25 gone, platelet 2 to 6 gone, platelet 2 to na ji na. They don't like thandi. So correct answer is option A, because packed RBC 2 to 6, platelet 20 to 24 and FFP is minus 25. Yes, the correct answer is option A here. Platelets never like sardi. They do not like cold temperature. So if I say whole blood bolo ya packed RBC, in both the cases my storage temperature is going to be your 2 to 6 degrees, and in that if I use the preservative of Sagum, that gives me the maximum shelf life of 42 days. For platelets, storage temperature is 20 to 24 degrees Celsius, and we have agitators. If we keep platelets, whether they are SDP or RDP, if I keep platelets with agitator, shelf life is 5 days, and without agitator, it is 1 day. For cryoprecipitate, for FFP, the storage temperature is minus 25, shelf life 1 year, and cryoprecipitate storage temperature minus 25. Again, the shelf life is going to be 1 year from the time of the storage. So that was it. Okay, now moving to the next question. A patient presents to me with hemoglobin of 9 grams per deciliter, RBC count of 3.2 millions, and hematocrit of 36%. Which of the following is likely the treatment to be given to him? हाँ जी, बताइए क्या लगता है आपको? Hemoglobin दिया हुआ है, hemoglobin is given, RBC count is given, and hematocrit is given. Treatment पूछा गया आपसे. Treatment is being asked. Yes, tell me. So if you look here, I know basic. I know the formula of MCV is hematocrit divided by RBC count in millions into 10. So hematocrit is what? 36. RBC count is 3.2 into 10. And this is going to be somewhere 112.5. And if I have MCV 112, that means I'm dealing with the case of macrocytic anemia, and if I go by that, the only option that suits me here is I will give vitamin B12. ये कैसे हो जाएगा? Oral iron तो हम oral और parenteral iron we give in microcytic anemias ना. So if I calculate this, MCV is going to be 112. It's more now, more than 100, right? So that means this is going to be a macrocytic anemia. So obviously I will give B12 or folate. Yes, option B is going to be the answer. ठीक है, चलो. Next question. Yes, a very important question. A 32, ऐसा similar, whether they ask you any defect, DNA repair defect, they ask you, giving a very important 3-4 line clinical history, ऐसा एक question जरूर आता है. So ध्यान से carefully, a 32-year-old man presents with multiple soft tissue swellings which are attached to the nerve. ध्यान से carefully, word by word, try to find the diagnosis here. This is a clinical integration. Multiple soft tissue swellings which are attached to the nerve. Multiple pigmented lesions are seen over the abdomen. Ophthalmoscopic examination reveals hematomatous lesions. Which of the following mechanism is related to the mutation that this patient has inherited? So if I look here, if I look at the entire history, this tells me that I am clear-cut dealing with a patient of Hanji. What is the diagnosis? Neurofibromatosis type 1. And in pathology, we read that in neurofibromatosis type 1, you have a gap mutation, GTPase activating protein mutation, because of which your RAS pathway keeps on working, more growth happening, growth, ultimately leading to tumors. So yes, the correct answer, very good, absolutely correct. The correct answer is going to be persistent activation of RAS is going to be there. Right now, but if I look at the rest of the options, NER, nucleotide excision repair defect, yes, it leads to what? Xeroderma pigmentosum, in future leading to skin cancers. MMR, mismatch repair defect, leads to HNPCC, also called as Lynch syndrome, in future leading to your intestinal adenocarcinoma. Next is your homologous recombination repair defect. Mnemonic, you remember, that was in the class. FAB. FAB means the patient is going to have Fanconi anemia, ataxia, telangiectasia, and B for Bloom syndrome. These are your DNA repair defects. Right? Clear to everyone? Okay, now next question please. Yes, all of the following are true except, that means I am being asked false. I am being asked false. So all of the following are true except. हाँ जी, क्या होगा बताओ? Chalo, let's talk about them one by one. In DIC, you see elevated PT, APTT, TT with low platelet and fibrinogen. Absolutely true. DIC mein your both intrinsic and extrinsic pathways are activated. So PT, APTT both are going to be elevated. There is going to be fibrinogen decrease in levels. So you will have elevated thrombin time as well. And yes, there is going to be your thrombocytopenia as well. So this is absolutely true. Next, only APTT elevation in hemophilia. Again, absolutely true. Remember, I always teach this. Isolated APTT increase in hemophilia. Absolutely correct. Next, elevated APTT with severe bleeding and factor 12 deficiency. No. Absolutely false statement. This is my answer. Remember, I always say that factor 12 is present in vitro, but it is not present in vivo. In body, you will have no factor 12 involvement in your coagulation pathway. So if anybody has factor 12 deficiency, they are always going to be asymptomatic. So severe bleeding nahi hoga, because in body coagulation pathway factor 12 is not necessary. That is absolutely wrong statement. Severe bleeding nahi hoga, there will be asymptomatic patient. Clear to everyone? Now just for completion purposes, last point is elevated PT and APTT and normal TT in vitamin K deficiency. Yes, that is absolutely a true statement. Clear to everyone? Correct answer is option C, because factor 12 deficiency patients are asymptomatic. They will not show severe bleeding. Done, done, done. Okay, now let's move ahead. Next question. All are true regarding breast carcinoma except. See, I have purposefully kept these except wala questions because they are very confusing. So dhyan se, jaldibazi mein we forget to read the except. No, you're not going to do that. So basically I'm being asked that what is the false statement. Chalo, let's talk about this. BRCA1 mutated breast cancers are usually TNBC, triple negative. Absolutely true statement. BRCA1 are absolutely TNBC. Luminal A subtype has best prognosis. Absolutely true statement. Lobular breast carcinoma shows CDH1 gene mutation. Absolutely true statement. Mucinous breast carcinoma is associated with bad prognosis. No, that is false. Mucinous breast carcinoma, they have better prognosis. So this is going to be my answer. But still, breast carcinoma, a very important topic. I want to talk about some important points here. Now, first thing, you know, lobular breast carcinoma, CDH1 gene mutation. That is why in these people, you will see a classical Indian file pattern on microscopic examination. Very, very important. Okay, now next, look here. Look here. See, mucinous breast carcinoma. Name itself is saying mucinous breast, because in this you will see the pools of mucin. So much of mucin, so much of mucin, so much of mucin, mucin. And in this entire swimming pool of mucin, you will see small islands of tumor cells. More of mucin, small islands of tumor cells, a better prognosis. So this is how a mucinous breast carcinoma is going to look like on microscopy. So in case if you see this image, this is a clear-cut mucinous breast carcinoma. I just wanted all of you to remember. Now these are screenshots from my lecture only, because I want to tell you important questions here. So for hereditary breast carcinomas, we have some high penetrance genes mutation and moderate penetrance genes mutation. Let me tell you, high penetrance genes which are involved in breast carcinoma, BRCA1, I told you they are associated with TNBC, triple negative breast carcinoma, which are ER negative, PR negative, HER2 negative. BRCA2 mutated breast cancers are usually ER positive breast cancers. TP53 mutated breast cancers are usually HER2 positive breast cancers. Another important gene which is associated here is PTEN gene. Very important question. PTEN gene se kya hota hai? What does it cause? Cowden syndrome. Cowden syndrome is going to involve which your cancers? So for that the mnemonic is BET. B for breast cancer, E for endometrial cancer, and T for thyroid cancer. CDH1 gene, we know that it causes lobular type of breast carcinoma. Apart from that, what else you see? What other mutations you see? STK11, LKB1 gene mutation, and last one, very important, PALP-B2 gene mutation. Very important. PALP-B2 is also associated with Fanconi anemia. This is your recent Robbins update, but that is by allelic loss. Moderate penetrance genes में कौन से आएंगे? ATM gene and CHEK2 gene, and CHEK2 gene mutated breast cancers are usually ER positive breast cancers. Now, when I'm talking about breast carcinoma, it is impossible that after mutations, I do not talk about this molecular classification with all of you. So according to this classification, I have 4 molecular subtypes: luminal A, luminal B. When do I call a female as a luminal A type of breast cancer? If ER is positive, PR is positive, HER2 is negative, and the proliferation index Ki67 should be less than 14%. And please remember, they are associated with best prognosis. They are associated with best prognosis, right? Luminal A has the best prognosis. Always remember this. Now, next is going to be your luminal B subtype of breast carcinoma. Now, there are two scenarios when I can label a female as a luminal B cancer: ER positive, PR positive, HER2 negative, but now the proliferation index is more than or equal to 14%. Or there's one more scenario when I can label a female breast cancer ER positive, PR positive, and HER2 positive. My next molecular classification subtype is HER2 enriched breast cancer. Name itself is suggesting you HER2 enriched means ER negative, PR negative, and HER2 positive. And the last one is going to be your TNBC. And please remember, TNBC has the worst prognosis. Name itself is again telling you that this is ER negative, PR negative, and HER2 negative. Now, in MCQ, there is one more name which is usually given as TNBC के लिए. There is also terminology used as basal type. So if you go and check this TNBC for low molecular weight cytokeratins, if this female comes out to be positive, we will label her as basal like TNBC. If she comes out to be negative for low molecular weight cytokeratins, we will label her as non-basal like TNBC. Basically, I just want to say basal, TNBC, please. This can be used as a word for TNBC, you have to remember. So these were the molecular classifications and these were the important genes which are associated with breast carcinoma. Please, 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 I do not want any confusion here, right? Next. So with this, we are done with all the important, which I could summarize in this span of time. But yes, before leaving, I want to say that these questions, yes, very important topics we have focused, but please, important inheritance list, I want all of you to go through. That has been shared in the DAMS Telegram group as well, and as well as on my Telegram channel as well. Please go through the list of inheritance. INI love inheritance patterns. They give you a long stem clinical history and then they ask you tell the mode of inheritance, right? So you please go through those important list, important carcinogens, very, very important. Please go through them. Your criterias are important. CML, blast, accelerated phase criterias. So there are some typical favorite topics which I want all of you to remember. So for INICET, my last advice for all of you is that please go through this predictor series, yes, go through INI-PYQs, yes, and your mission INICET that is happening on DAMS YouTube channel itself. Please go through these things so that what is going to happen, the predictor, the mission INICET and the INICET PYT and PYQs, they are going to cover the entire 360-degree approach, that what are the bullseye target points that are favorite for INI examiners and which you have to go through, right? So we are trying best to give you all the high yield, crisp informations for all of you. And it was a lovely session. Thank you so much, guys. And I wish you all the best. And I'm sure you are going to rock for sure. So good night, everyone, guys. Take care, stay safe, stay happy. Thank you so much.